Well, hello everyone. It's now 9 o'clock Pacific time. This is Mark Musin from Stanford University, and I'd like to welcome you to today's continuing series of seminars in the Big Data to Knowledge Program's Guide to Fundamentals of Data Science. Today we have the honor of having Bartha Knoppers from McGill University, where she's director of the Center for Genomics and Policy, offer us a talk on ethical issues related to data science. Dr. Knoppers is a professor and holds a Canada Research Chair in Law and Medicine. She's a member of the Scientific Steering Committee of the International Cancer Genome Consortium and co-chair of the Regulatory and Ethics Working Group of the Global Alliance for Genomics and Health. Her PhD is in comparative medical law. She has 4 honorary doctoral degrees, is an officer of the Order of Canada and Quebec, and it is a real honor for me to introduce her and for us to have an opportunity to hear about this really important topic. Dr. Knoppers.
Thank you, Mark, and hello, everyone. Before I begin, I'd like to thank Mark Phillips, Research Associate, who is here with me at McGill, for all the work that he put into helping me prepare for this presentation. I've received instructions to keep myself to 40 minutes to make sure you all have time to ask questions, so I will do that. Just by way of preparation, the outline of my presentation, I will look at the current sort of self-regulatory approaches to the big data and ethical issues that surround the use and creation, access, and so on of big data. The commons approach, which some of you probably are aware of and others less. Future governance approaches, and a new proposed human rights approach to the future of big data, and conclude with some personal comments. I'd like to also stress that throughout my presentation, I'm concentrating on biomedical data largely. I note by looking at some of the past presentations that, of course, big data crosses all the fields of social, pure, and applied science. By way of introduction, just so you don't think that preparing for this, and particularly looking at the privacy issues of big data in the biomedical sphere, I consider biomedical, including the medical part, to be quite large. In other words, to truly move from research to the bedside, you have to obviously take into account geospatial data, surveillance data, traffic, socioeconomic data, and so on, before you can put the data together to come to any kind of predictive modeling. Now, today I will be concentrating on largely privacy and data protection, but most of you are aware that since the Human Genome Project and its completion in 2003, there's been a question: what do we do with it now that we've found the sort of the sequence, the human genome at the level of the genome, the human genome? How can we unlock its health potential in a way that allows data to be shared in a secure way, I should say, on a global level? The thesis then, or the hypothesis, is that we will not get from the human genome to the population, to precision medicine, to the patient, unless we really move from populations to subpopulations in a sort of stratification approach, which again would regroup data at community levels or subpopulation levels, and then and only then can we move to the patient, taking into account that under the sort of new emerging healthcare learning systems approach, patients themselves will soon, hopefully, be part of this healthcare learning system, moving from use of their data and samples in medical care into research and back to the patient in order to be more precise. So it's sort of a feedback loop system that I'm looking at, a population to subpopulation to patient stratification system. And finally, the other contextual background before I begin on the self-regulatory is the fact that international scientific collaboration is exponential. This graph means nothing. Scientists told me that most of the equations are incorrect, but I liked the way it was drawn. So I used it as a background for this, just to remind you that sort of the individual eureka scientist working, alone in a lab still exists, I hope still exists, but we're moving more towards a large consortia crossing different jurisdictions with different laws, different cultures, and different values, and that in order to create big data, to use big data, we have to keep that in mind, and particularly different approaches to privacy and security. So what is actually there to help, to guide, to frame at this point in time in 2017? Well, up till next year, there are privacy guidelines from the OECD since 1980. Next year, the General Data Protection Regulation from the EU will come into force, and I'll speak a bit more about that later, because for data to leave Europe or to enter Europe, we need to be cognizant of what the impact of that data protection regulation will be, and the APEC cross-border privacy rules. Now, these are privacy rules for personal data, well, of all kinds, whether it's socioeconomic, whether it's credit, whether it's demographic or medical. None of these guidelines to date are specific to the protection of health information privacy. And so you'll have to take them as they emerge, even the data protection regulation, which, by the way, is going to be a regulation, which in Europe means it's law. Right? Before, we had a directive. Now it's moving towards a regulation, which means that countries will be less free to sort of interpret it liberally or conservatively in their domestic legislation. This will actually be across the board regulation and be mandatory. So we'll have to see what this means for data protection and data sharing across borders, moving from Europe, within Europe, and overseas. Now, one of the first sort of self-regulatory organizations to jump into the fray to bridge this gap between the sequencing information, genomic information we have, and the clinical, the medical, to bring the two worlds together is the Global Alliance for Genomics and Health, which was created on January 28, 2013. Now, unbeknownst to most people, this is just a large international organization of volunteers, institutional volunteers. There are companies in there, IT is in there, your typical academics are in there, your patient foundations are in there, individuals are in there, and so on. It's simply an organization that wants to prospectively, if possible, ensure interoperability, harmonization, protection of participants, and catalyze, if you wish, in a positive sense, data sharing by creating tools, framing policies, and so on to help, to encourage, and to facilitate data sharing. It does not hold data. It is not in any way bound by any organizational rules. It's not even incorporated. So it's actually what I call an army of volunteers who would like to move from the mapping of the genome to an international approach to data sharing. It did, however, develop a framework, which I'll come back to later under my human rights approach, and immediately after the framework in 2014, did a series of policies, of clauses, of templates, a lexicon. I can tell you that took a lot of lawyers to play around with words like de-identification, anonymization, pseudonymization, and which all tend to mean different things in different countries, but a need to be understood for data access and sharing. A privacy and security policy, a paper on data safe havens. What are the attributes of a center or an institute or a project that says you can deposit data here, like dbGaP or EGA in Europe, and it would be considered data safe haven, and you don't have to spend hours and hours in front of data access committees or ethics committees trying to explain. An accountability policy and an ethics review recognition policy. So I'm just going to take a few minutes to give you sort of the highlights of, particular highlights of what you might say is just sort of a normal approach to these issues. The first issue that everyone asked about when it was created in 2013, all the way to the time of the framework and then the consent policy, was what do we do with data where the word international isn't mentioned, where the word sharing isn't mentioned, out of the country is not there? How do we not lose the contributions of citizens, either as patients or as research participants, by enabling and facilitating, and in a responsible way, the sharing of legacy data, and this within borders and across borders? So that's a unique feature of this consent policy. Similarly, for privacy and security, rather than taking the clinical trials model where there is a high risk of harm, drugs, devices, sham surgeries, placebos, et cetera, how do we apply or not apply privacy and security policy into what is largely data-intensive science? So the Global Alliance concentrates on data-intensive science. It does not get in the way of the ICH clinical trials, internationally accepted approaches. And so it asks the question, when you are looking at harms and benefits, look at real harms, not some hypothetical one day somebody somewhere might do something perhaps, real harms and real benefits, and take a proportionate approach in evaluating risks to privacy and data integrity. In the same mindset, in the accountability policy, whether it's editors, whether it's funders, whether it's researchers, institutes, universities, governments, if you do have data that is, this is just one element of this policy, it's more complicated than that, but if you do have data that's consented for sharing, why aren't you sharing it? And this, believe me, this sort of data hoarding or sitting on data, actually the Global Alliance considered to be an ethical issue, and so the accountability policy speaks to that. And finally, the last policy is the ethics review recognition policy, which is just been put 2 months ago on the website of the Global Alliance. The ethics review recognition working group looked at the different kinds of models. I know that the new Common Rule proposes a central IRB in the NIH fund projects in the United States under the Common Rule, but we looked at reciprocity, simply having your sort of recognition that your procedures are the same, the way you handle composition, the way you look at applications, the way you adjudicate, the way you respond, and so on, the characteristics or the attributes that you use to evaluate. So whether the lead researchers in Germany or Japan, we will recognize the IRB decision of the other, and so on, a delegation model, a federation model, and so on. And I think the new ethics review recognition policy gives you the kind of processes that could be considered international to allow, or to hopefully one day allow international consortia to adopt this approach. So that's those are the most recent workings in the field of big data and facilitating the ethics foundations of big data that the Global Alliance has provided. Now, even the Human Genome Project has been characterized as one of the first projects that actually took a commons approach. And what do I mean by that? Obviously, the word says it all. There are experts and there are many professors who have written about this, is holding things in common, putting things in common under the notion of global public goods and a common heritage and so on. Why is this important? Well, in PLOS on April 17, we already see that where you have ready accessible access across countries, across borders, and particularly in the case of rare conditions, you can actually solve or at least diagnose, you might not have a treatment or a cure, on the case of a patient in front of you. And this is thanks in part to this commons approach. Now, there are, so these are with respect to genomic databases that allow you to connect electronically and exchange information in real time and very quickly. There's different kinds of commons. This is a very good article that appeared in Science by George Contreras and Reckman on the different types of commons that exist. Now, here at McGill, we've been working for a while under what's called the Cancer Genome Collaboratory with Lincoln Stein, trying to create a cloud commons for cancer data. And obviously, what was behind this or spurred us to do this was the International Cancer Genome Consortium, ICGC. And we needed to prepare the ethical and legal and aspirational, if I can say that, foundations for crossing all cancers, all countries, and being able to share data. Well, the hopes are high that the cloud permits us to do computing in real time and to look for patterns that of disease or health that then allow us to formulate hypotheses, which is an interesting new way of doing science. Rather than having a hypothesis and going to the data, go to the data for your hypothesis. And this Cancer Genome Collaboratory has been successful not only because it answered many technical and overcame many technical barriers due to the sheer volume of data, but it also created, if I can say this, a new community that actually now has been transformed into the Genomic Data Commons, as it's known since 2016. So this new kind of intellectual data-intensive commons, with a particular approach to the genomic commons, was actually why I call it self-regulatory. It came from the researchers. It wasn't something that just appeared on the market as a piece of software. They actually developed it because they needed it, and they saw that this was the way to do data-intensive science in a humanistic sort of way by data sharing. So it maximizes research benefits, which are often publicly funded, at the same time offering privacy protections. Now, there are many worries, as you know, about sharing data, particularly in the cloud with the NSA, Snowden, and the rest. And so moving forward, we realize that with some European cases, as lawsuits as well, that the more contextual data we bring in, including, let's say, geospatial, where you can see the socioeconomic effects of lack of universal health care, lack of sidewalks, lack of public health strategies, lack of fresh fruit or vegetables or water, clean water. You could all bringing all this together can have different impacts, not just on the individual and, in quotes, discrimination, but in different contexts and with different human rights that are affected. And there's also the issue of lack of control, legal enforceability, and what about use by the state for surveillance? Yesterday I was reading an article about what do we do about Facebook when you can see actual murders being committed. I mean, you actually have to think about how much freedom do we have at the same time that we know that there is a need for oversight and some monitoring to address those risks. And data privacy and regulation has not been drafted with big data or the cloud in mind. So how do we then move towards the future in handling? I think most of the people who would have signed up for such a webinar would be well aware of the privacy, security, and social risks of big data. So turning then to future governance and big data issues, the next slide, looking at it from a systems approach, an interoperability approach, comes from the OECD. And the OECD convened a working group from 35 member countries to look at health data governance. There was a common understanding that you need data linkage. You need linkage between not only individuals as individuals move around, but individuals and other data sets to answer specific questions. What we all want, hope, and are waiting for is linkage to electronic health records. And this not just for an individual case or a rare disease somewhere or a particular, to look for a particular outcome, but longitudinally to be able to follow individuals through their record that's linked to other records, cancer registries, morbidity, mortality, the kind of, or even census records, to be able to come to a level of understanding of the impact of the environment writ large on why some people are healthy, we always talk about disease, and why others are more susceptible or likely to become ill, even leaving genetic factors out of it. So this pathway then, and all the data trajectory has to look at the outcomes and costs of having access and using data or not. This means that one of the key prerequisites in this healthcare learning system is to be able to follow patients. So not just your big research projects, your 500,000 in the UK Biobank following people over time, or Estonia Biobank, or Japan, and so on, which are wonderful and interoperable to some extent, but patients from birth to death. So the rationale then for this OECD recommendation on health data governance, which came out on January 17, 2017, is that health data can advance health policy objectives. So if a particular country has a particular health policy, be it child health, maternal health, aging health, they can actually have access to the data that they need to project, to plan, to promote, and to prevent in a system sense. Now, there's no country that is immune from using health data. And so what are the obstacles to using health data effectively? I mean, what good is a deluge of data if you can't decipher it or use it? And for this, we need better policy frameworks to get more out of health data. So the OECD came up with a series of 12 sort of broad measures accepted across the 35 countries. And believe me, this was quite political. It's also cultural. As I say, things like public interest, public health are interpreted differently in different countries, some narrowly, some more broadly. So these are the large categories. And under each of these categories, there are actually procedural guidance is provided for these measures that countries can then incorporate into their national domestic legislation or their health care framework or system, however it is structured. Particular interest to me was this one, where it actually came out and said that government should support trans-border cooperation in the processing of personal health data. And not just to make the systems more cost-effective or even, let's say, sustainable from an economic point of view, but also for research, for statistics, and other health-related purposes that serve the public interest, and obviously with certain safeguards. So they recommended to identify and remove barriers to this, because it's the easiest thing to say, well, you know, this is the law in the country, and just hide and run behind it, and that's it. Typical lawyer answer, by the way, and obviously sometimes not even 100% true. You can also facilitate the compatibility and interoperability of health data governance frameworks. Look what works in other countries that have a more international sharing approach. What works, what doesn't work, and why, and how do we remove those obstacles, and what are the mechanisms for that. So this is where I come to probably, this is more of a personal recommendation, but it's definitely the one that founded and underscores all the work of the Global Alliance, and that is let's switch things around. Let's switch from a sort of bioethics framework that has been largely accepted in the the Nuremberg Code, the Helsinki Declaration, et cetera, one that sort of sees research as necessary but potentially harmful, and almost creates sort of a burden of proof on researchers to overcome to show they're not going to harm someone. And with that in mind, of a sort of a positive approach to science, went around digging, as scholars are supposed to do, and found that in spite of my legal education, I had totally forgotten and had missed, and as most people did probably, International Public Law 101, which included the Universal Declaration of Human Rights of 1948. And in that Universal Declaration, there is an article that talks about, in the first section, the right to science, and that includes the right to share in scientific advancement and its benefits. Luckily, for all those inventors, scientists, artists, and so on, in the same article, there is the right to recognition for authorship, for being an inventor, a discoverer, coming up with something that is recognized under intellectual property, copyright, and the like. Now, I'm not going to talk about 27.2, but it's interesting to note that they do go together. So it's not because you think everyone, should share everything and everybody should have everything and that we do not need to recognize the fruits of intellectual contribution. So keeping that in mind, you say, okay, that's a Universal Declaration. Looks nice, paper, seen Eleanor Roosevelt in the films on it, and so on and so on. But it doesn't concern me. Well, it does. Because in 1966, these two rights under Article 27 were rendered legally binding. Again, something I totally missed, by the International Covenant on Economic, Social, and Cultural Rights. 66, by the time everything got done and everything was ratified, I think it was 1976. And in Article 15 of that binding international covenant, you find the same twin rights. And 165 states have signed and ratified. Once you sign, that just means you have the intention to that you agree with it. But if you ratify a covenant or treaty, it actually enters into your local domestic law. So you're bound to implement it, which means that citizens can call their governments accountable, make their governments accountable for implementing the treaty in their own country. So it's universal, 165 countries. I won't tell you which countries have signed or haven't. It goes beyond the moral appeals of bioethics, moves you right into the human rights sphere, so the international legal force. And being a human right, it belongs to groups as well as individuals. So you don't get that, not only individual autonomy, individual protection, it's group rights, group protection, group promotion, in a sort of reciprocal approach, and imposes positive duties on governments and private actors. And actually, we're center here, we're looking at what the countries have done who signed and ratified in their reporting to the United Nations on their obligations under binding treaties, or they send in reports. So we're looking in right now for the last 50 years or so of reports to see what they've done about this actionable right to science and its benefits. In the meantime, 2009, UNESCO started looking at this and took a kind of a broader view under the Venice Statement of the right to science. Obviously, access without discrimination. There will be no benefits if you can't access it. Opportunities to contribute. Freedom. This is a popular interpretation of sort of put together this right to benefit from science with the expression of yet another right, which is the right to freedom of expression, scientific expression, and so on. Participation in decision-making and conservation, development, and diffusion. So it's quite broadening out, if you like, and they didn't particularly spend a lot of time on just the right to benefit from science and its applications. This, however, was taken up by the AAAS in 2010, and more from what is the role of the scientific community to nurture awareness of the broad social context and the human rights implications of Article 27 that then became Article 15. And the AAAS has just finished a survey across all its members. All the scientists are in there, from people studying dinosaurs to data, social sciences, you name it. And the results should be coming out. It'll be very interesting to see their work. And as we know, they're very active recently in the other right, the right to freedom of expression of scientists and so on. And finally, looking at the work of the GA4GH in this area. Now, when the framework was written, we were quite aware that we're not starting from scratch. There are other human rights, as I just mentioned, the right to scientific freedom and so on, that have been developed that work towards respecting Article 15. The right to privacy being one, anti-discrimination, fair access, and obviously procedural fairness. So there is background. There are other stones that are there already building the foundations for the realization of the right to benefit from science and its advances. So when we wrote the framework, we tried to keep it on data intensive set. We tried to keep it simple because we wanted it to be used and understood and be sort of like a handy small handbook, if you like, very short, for scientists. So the aims are broad. Under each aim, there are procedural mechanisms, but the difficulties with doing this, with writing such a document, a framework across all countries, is what we try to do, is to keep it at a level where each country can see themselves culturally, value-wise, religion, science, socioeconomic, within the framework. So the thing was to keep the lawyers, including myself and so on, from adding too many words, because that's how we're brought up, and how to train us to keep it simple. And by the way, it's been translated into 13 languages, and again by volunteers, and validated in cross-translation back to English. So here are the core elements. You can see that they're a little bit different than your usual autonomy, privacy, justice mantra that most people working in the field of bioethics and law are used to, and they're more specific to data-intensive science, and they give three, each one has about 3 mechanisms for how to apply them and then have them interpreted in your local jurisdiction. So what else is happening as we move towards the data commons, or the biomedical, or as the CIOMS would say, health-related data? I think that's the key here. We're moving from the genome to biomedical to health-related. Health as defined by the WHO as not simply being limited to the absence of disease, but actually looking at the well-being and welfare of individuals and populations. Well, earlier I mentioned this new EU regulation, the General Data Protection Regulation. Trying to get a head start on what it means and what it can mean, the first is probably this PCOG paper, which is a pan-cancer analysis working group paper that within the International Cancer Genome Consortium tried to cross the cancers, the pan-cancer, in a scientific way to come up with different conclusions on trends in the future and so on in terms of cancer data inside the collaboratory that I mentioned earlier, and together with the EU Open Science Cloud. So this is a big project that will be probably published this year in 2017 in Nature in a series of papers. What we're trying to do is look at this EU regulation and say, what does it mean for scientists? It's heavy going, I have to tell you, even as a lawyer, I find it, pretty dense. What does it mean to be identifiable? We all know that if you put together data from here with a sample from there with other data from somewhere else and another sample who knows where, that potentially everybody's identifiable. Okay, so got that out of the way. That doesn't mean that you can't do anything because there's a remote as opposed to a reasonable likelihood of re-identifiability. So who actually are controllers versus data processors under this new regulation? Because they have different rights, they have different responsibilities, and it's people change roles. I mean, are the annotators curators? Are they the processors? Are the data protection commissions and agencies? Are they the controllers? And what about the data subjects? You probably heard you could not only say yes or no, you can object to different uses, you can ask to be erased or the right to be forgotten, the right to access, to say, give me my raw data, I don't care if I understand it or not. Is that going to be the new way of the future? So we have to get some clear guidance on what the duties mean under this new regulation. We also need to simplify. A lot of consents are so specific that they have more constraints than they have consents. So considering that while we're moving towards a broader consent with better governance, because if you're going to make that leap of faith and the trust, and we know broad consent is now also allowed under the common rule, we need to know that the governance is there, the oversight, the monitoring. But even for very specific disease projects, and a lot of countries still are quite strict about whether data leaves or not, or if you say breast cancer, it can't be used for ovarian, and et cetera, simplifying the international sharing by having codes to identify what can or cannot be done, rather than complicated data access and data material transfer agreements that take more time than the funding of the project that's looking at the particular disease. So that's the consent codes developed under the Global Alliance. We also have something called beacons. You probably heard of these. Have been around now for a year or 2 years, I would say. It's just, like a bing, sending out sort of like a lighthouse. Anyone seen this allele? So it's a discovery tool. It's not a diagnosis tool. It's simply saying, anyone have anything that looks like this out there somewhere? And it's very simple, and because it's such high level, before you go into more clinical stuff, where obviously you would need consent and so on, you can actually discover who has what where, and perhaps collaborate in future projects. And these beacons are now around the world, so that's great. A more recent project between the Global Alliance and the International Rare Disease Research Consortium is this one, the privacy preserving record linkage. So at the beginning, we talked about the need to link and why it makes for better outcomes, better diagnoses, better programmatic decisions, and so on and so on. But you don't want to be linked by anyone to everything anywhere at any time. You want to make sure that if your data is transferred for public health purposes, or for your own diagnosis, or for your own subpopulation or community project, that you're able to do it in a trustworthy, secure way in order to get the metadata that's needed to make those calculations. And you don't want to be counted twice. This happens, and the Rare Disease Consortiums are very aware of this, that you think you found 12 families who have X, and you're all excited, and then when you get the samples and you put the data together of those 12 families, you realize that in traveling around the world looking for help, looking for diagnosis, looking for understanding, often samples and data are left in different places with different experts and are counted. So this is the deduplication. And the more we do linkage, the more this is going to be an issue, not just for rare diseases. So we have all kinds of privacy protection people, security people that understand all these things like hashing and cryptographic and other tools. And this is moving forward and should be a project hopefully done by the end of this year. And finally, we know that right now there's open access, open for aggregated data. And we know that access to such data is really important for statistical purposes. And we also know that we have data access committees for what we call controlled access, particularly even in the International Cancer Genome Consortium and so on. There are these committees that will then check that a project can release data in a secure way. So that's good, the controlled access, and perhaps we should need to keep it for sensitive data, for children, for vulnerable populations, and so on. But isn't there a middle road somewhere, what we would call registered access, almost like an ethics committee where you have expedited review, where we could have an online system with some authentication of the applicants, but not all these data access agreements and interinstitutional agreements and data access committees that have to meet, that have to send reports, that ask for, and so on and so on. Can we build a system that is for data-intensive, less sensitive, low-risk data, a faster but trustworthy access system? And we're calling it registered access for now. So that are some of the tools that are emerging, and if anyone online has or on this webinar has ideas for tools that they need or work that they want done, you just contact the Alliance. We build working groups as requests come in and as volunteers say that they're going to work on them. But I think the most important thing between the Commons, the Alliance, the Global, the sharing and so on is that you can see that they say, you know, you stand on the shoulder of giants, but the giants really are just people, individuals collaborating and sharing, and there are really no giants per se in this effort to ethically share, use, have access to big data. And there's the team here at McGill, not only the Center for Genomics and Policy, but the P3G, Public Population Project in Genomics, which is the tool building arm, and CGP is the research building arm. So I'll stop there. I think I'm exactly on time. It's lots of time for questions.
Great, that was wonderful. Thank you very much. Again, this is Mark Musin from Stanford, and I'll try to moderate the question and answer period today. Probably the easiest way to manage questions, given the large number of people who have dialed in, would be if you have a question, please type it into the questions chat box on the GoToWebinar site, and we will make sure that we get your questions answered. It's going to be hard otherwise to have 100 people ask questions at once. While we're waiting for people to type in their questions, let me ask a question myself then, since I can take that prerogative. You spoke a lot today about the idea of privacy and protection for data that is a consequence of sponsored or carefully conducted research. One of the areas in data science that is beginning to get a lot of attention are the ethics associated with the use of data that are collected not as part of specific experiments, but that are collected routinely. And a lot of conversation about the use of routinely collected healthcare data, for example, in the case of electronic health records, that could be used to guide decision-making as part of a learning health system. Whether patients who have their routinely collected data contributing to analyses that could inform treatment for other patients, or whether it is ethical to be using routinely collected data to guide therapy of other patients when those data have not been actually collected in any kind of a controlled manner. And I'm curious if you have any thoughts on that.
Oh, thanks for that question. I was at a meeting of the American Epidemiological Association last year, and somebody actually brought that up and said that there was a duty, I would probably subscribe to that, but a duty to share such data so that you as a patient can benefit from the routine collected data and the mistakes made or the right treatments chosen or the right intervention that was taken or drug prescribed from the patients before you. And your scenario then contributes to the better treatment understanding of the patients that follow you in the world, in the collectivity of your status as a patient. I find that quite compelling. I'm not sure how often that is done yet, and whether perhaps while we're thinking about data sharing, it is in the medical clinical environment that we've done a lot in the research ethics department and data security, do clouds, regulations. Have we looked at how to routinely use it, share it in a responsible, governed, monitored way? I'm not so sure. I mean, I would be hopeful that it is being shared from a quality assurance point of view. I'm not so sure that, as you mentioned, that it's not sort of a willy-nilly freewheeling thing right now.
There's a corollary question that came in the chat box, which is, when is data gathering considered, quote unquote, for health versus as part of a research study? How do we make that decision?
Yeah, well, that's where the healthcare learning system comes in. I think this has tremendous implications. I know about, the codes of ethics for doctors. I know about the research ethics for researchers. But if patients are going to become part of this feedback loop so that they can benefit from research using their data and samples individually and collectively, I think that distinction, which currently does exist and absolutely is everywhere, between the healthcare duties and privacy security and medical records versus research ethical duties and keeping of records and certificates of confidentiality and the like, that schism still exists. But I actually see that it's probably going to be not totally disappearing, but definitely lessening in the next 5 years, and maybe a decade from now it will be gone.
Interesting. There's a question a user has posted. Will you please provide the contact information for requests for policy development? Also, who can participate in the working groups? I might suggest that when you upload a revised version of your slide deck onto the website, perhaps you might be able to include that information as additional slides that people might have access to.
Yeah, we'll do that. Just go to the Global Alliance for Genomics and Health, and you'll get, you can become a member. The only thing you have to agree to is the framework. You don't even have to agree to share data to be a member of the Global Alliance, even though it's a fundamental tenet. But it's as I said, people get together from different countries and on the different working groups. There's tons of them. So just have a look at the site, and I will put the address on my next set of slides.
Here's almost a cynical question. In the genomics era, can individuals expect privacy? And if no, how would each individual be protected with respect to insurance, the privacy of their diagnoses, and so on?
Oh, yeah, I forget. I wanted to cut it out and paste it on my office door. It was about 5 years ago. Privacy is dead. It was a big thing. Maybe it was Time magazine or something. I should have kept it. Well, we do live in society, so if you have a sort of atomistic view of privacy, you're living in a cave somewhere, or you're alone in a valley between two mountains. Other than that, I don't think privacy is totally dead, but I think it's dead in the sense that the more you participate in the social media, or the more that you want systemic approaches to education, to highway safety, to airline safety, to health, quality health, there is a give and take, and there is some, you cannot expect to have better treatment without better knowledge, which of course means giving up some privacy. No one, however, has to participate in research. I make that clear. In a hospital setting, quality assurance is extremely important, or you get something else other than the condition that you came in for, if there's no means of controlling the quality, but also having access to data for patient care.
I mean, regarding that expectation of privacy, I'm reminded of the controversy in 2014 when it was exposed that Facebook was doctoring the news feeds of people, trying to determine whether increasing or decreasing the amount of happiness in the newsfeed would affect their posts. And I think what was most remarkable is that most people seem not to care. I think the professional ethics community was outraged that this was obviously an intervention that was done without any kind of informed consent. And yet most Facebook users didn't seem to care much at all and seemed to suggest that, well, we know that Facebook is creepy. And I think for me, it certainly marked a change in the way I think a lot of people are perceived to view the protection of their data.
Yeah, if you want your data I mean, Facebook is one thing. You can be on it or not. That's a choice. But I'll just give you a very mundane example. I find myself getting coupons in the mail for the store where I go every Saturday to groceries, and I get points on exactly the products that I buy. And so I know that, it's not just, there are means, because everything is transmitted electronically, to follow your patterns, to know what you do, to sort of figure you out commercially or for marketing or whatever. Most people actually don't care, and I'm wondering if sometimes, and mea culpa, bioethics and legal / community, if sometimes we don't create problems that most people don't really see or care or worry about.
There's a question which I'm not quite sure I can parse, and maybe the question I might want to follow up with something more precise. How does data ownership or the ethics of the benefits of ownership fit in here?
Yeah, ownership / property, as you know, is a really thorny issue. Most individuals, legal scholars would say there is no per se property right in data. Now, that doesn't mean that under any system, whether they use a personal rights system or a property system, as you know, property, you can have a very simple property right, which is to control its use. You might not have the right to sell it or whatever, but you would have a right of control, even under a property system. Under a personal rights system, which are a lot of civil law countries, again, the question of integrity, personal integrity, allows you to control the use of your data. So I think ownership only comes into question when you have something that's data that's transformed and becomes valuable. In other words, has been transformed into a product that then can be sold or owned. Now, there is some question in Europe that databases in and of themselves might have property interests, but I'm not going to get into all of that, because I used to teach property law, and I think I'd bore everybody on this webinar with that.
Are there any other questions from the audience? Well, if none, let me thank you. This is a very difficult topic. It's also a very important topic, and I'm really grateful that you had an opportunity to share your thoughts with us today.
Great. Thanks, everyone. Hope it was helpful. Bye-bye.
Bye-bye.